This week we're going to talk about regulations, similarly to when um, a restaurant has an inspector come in to check how they're, serving food and making sure they're keeping things clean. Facilities throughout the area also have to have regulations that have to be met at a state, city, and national level. CMS created the Medicare Provider Certification Program, and this program ensures that the institutional providers that serve Medicare beneficiaries, for example, hospitals, SNFs, LTACs, and the home care health agencies and assisted living facilities, are meeting the minimal health and safety requirements. In order for them to participate in these programs, they have to meet certain guidelines and regulations. So, how they find out whether or not these facilities are doing that, the institution undergoes certification surveys to determine their compliance with conditions of participation. These surveys are conducted by the State Department of Health, or private accrediting agencies or organizations, for example, TJC. So even in the hospitals, they have a company called JACO that comes in, I believe, once or twice a year just to check and make sure things are being done right according to regulations. So when we're thinking of the private sector accreditation, as I had formerly stated, JACO, we call it Joint Commission, TJC, is the primary organization responsible for standard setting and voluntary accreditation of care providers and alternative settings. So TJC develops and publishes standards and national patient care safety goals for long-term and subacute care, home care, and also assisted living facilities. So the standards cover patient rights, ethics, assessment, and organizational leadership, as well as management of information. So patient safety goals target improvement of common problem areas. They're always talking about patient safety goals in the acute care setting, making sure that we're using the proper ID, checking name and date of birth. Medication safety, that's the five rights: right site, medication, right delivery, and then also infection control is a big deal because you don't want to have a widespread cross-contaminated epidemic in the hospital. So they have to make sure all guidelines are being properly followed by according to state regulations. On this slide, you see 51-1 is talking about discharge planning for the respiratory care patient. And this is according to AARC clinical practice guidelines. Indicatively, when a patient is admitted, most of the time the case managers are already looking at planning for discharge, or asking the patient and the family, what do you think are the things you're going to need for when you go home? So depending on the course that the care takes as far as their condition will determine what's going to happen at the end. But they're always trying to look at these things early so they can plan early in case the patient has to be sent to a facility. They can already reach out to the facility ahead of time and say, hey, I potentially may have a patient that's coming, and to see if they have openings and beds available and things like that. So discharge planning is indicated for all respiratory care patients being considered for discharge or transferred to alternative sites. There's really no contraindications unless the facility cannot accommodate the needs of the patient. But the natural course of the disease or other factors beyond the control of the discharge planning process will be considered possible complications of the discharge plan of care. So the method for discharging, you want a discharge planning and implementation, like I said before, should begin as early as possible. The complexity of the plan is determined by the patient's medical condition, needs, and goals. So below, under the section of method, there's a whole list of planning processes that are there that you can kind of familiarize yourself with. So we got patient evaluation, patient's medical condition, the psychosocial condition, not only of the patient but the family. Sometimes the family can be a hindrance with the transfer process, especially if it's somewhere that they don't want their family member to go and they can't take care of them at home. The respiratory and ventilatory support required, desires for medical and ventilatory care of a patient and family, patient's physical and functional ability and activities of daily living, goals of care, whether it be from the patient, family, physician, healthcare professionals, bedside caregivers, site evaluation of continuing the care as far as the personnel, physical environment, safety, suitability, equipment and supplies, and of course the financial resources. Insurance plays a big role in whether or not the patient can go home, whether it's better for them to go to a facility, and whether or not the proper reimbursement will be there to take care of what it is that the patient would need. So the discharge plan provides the foundation for quality post-acute care. It's important that we look at the discharge plan, especially ahead of time as respiratory therapists, is if the patient's alternative site may be a facility or home, we have to make sure that proper teaching and things like that are in place, especially if it's a SNF and things like that where they're not used to taking care of the patient. Sometimes they'll send out a caregiver or a nurse to learn if it's something that they're not used to doing. So we can teach one person and they'll teach everyone else. If the person's going home, we have to make sure proper teaching has been implemented so the patient or the family members, caregivers can be effective at taking care of the patient in the home care setting. But a proper design and implemented discharge plan guides the multidisciplinary team in successfully transferring the patient from health care facility to an alternative site of care. Effective implementation of the discharge plan also ensures safety and the efficacy of the patient's continuing care. So primary factors determining the appropriate site for discharge are the goals and the needs of the patient. So we always kind of have to look at where is the disease process going? Do they need more time for rehab? What is the proper place to send this patient so they can get either back to baseline where they were prior to going to the hospital, or you be able to be rehabbed so they can go back home. So goals and needs should be met in an optimal and cost-effective manner using the resources available at the proposed site. Staff must have all competencies required to meet the patient's ventilatory and respiratory needs and be able to provide other healthcare services and provide 24-hour care. For the discharge home, it's imperative that a caregiver's abilities to learn and perform the required care be evaluated before transfer. It's required, when I worked in the LTAC, that 2 caregivers had to be able to perform the competencies of trach suctioning, trach care, and if they were going home with a ventilator, that at least 2 people were trained to be able to work the ventilator and learn how to do emergency situations such as changing out the trach or ambuing a patient, so they wouldn't be calling the local 911 all the time for help. So we had to make sure that they were competent and comfortable before they left. So caregivers must demonstrate the competencies required to the care for the patient, and there should be the availability of 24-hour care. So we make sure it's very clear to these caregivers that you're doing this training and there's 2 of you as backup to each other, but someone has to be there to take care of the patient 24 hours. It's a very big obligation, and a lot of times a lot of the families can't do it. So improper or premature discharging of patients to alternative care settings and poor care plan implementation can result in short-term readmission, almost 20% in COPD patients. I can remember so many times that we would discharge a patient before the LTAC and the more skilled subacute facilities came into play. We would see these patients, they were discharged, and not even 24 hours later, they were back at the hospital because they had another flare-up or exacerbation. And the facility that they went to didn't know how to handle it, so they just sent them back to the hospital. Now they're putting regulations in place that if these patients are readmitted, I believe within 24 hours, the hospital is going to lose funding, and they will not, possibly part of the admission will not even be paid for if they can't make sure that the patient is properly set up to go home or to the facility where they're transferring to. So what can we do to minimize the risk of readmission? Below is a list of things that we need to look at as caregivers to ensure that these patients do not come back. We have to make sure that we properly screen the patient, evaluation and appropriate discharge planning. From the moment that they have admission, we want to already be looking at the discharge and what they anticipate the needs that the patient may have when they go home. The multidisciplinary care plan, so all different areas we should be looking at as far as nutrition, equipment, teaching, making sure we're looking at all these things in advance. So if the caregivers need to be taught how to do trach care, or they need to be taught how to suction the patient, or they need to learn how to work the ventilator, then we can have them come in a few times and go over these things over and over again to make sure the patient's family member or caregivers are competent. Proper care plan must be implemented to make sure there's no needs or anything that they need before and after they leave the hospital, and then we always want to do a patient follow-up to make sure everything's going well, so we won't have a readmission. We can kind of talk to them early and then kind of step in at that point to get anything that the patient need, even if it's just kind of being a go-between for them and the doctor as well. So in the 1990s, there was a thing called the Medicare Prospective Payment System, PPS. And this was the reimbursement for many types of respiratory therapy equipment in alternative sites based on, of course, predetermined monthly payments. So what does this mean? This means that certain types of equipment are categorized in capped rental items. So when we say capped rental items, we're saying that they are eligible for reimbursement under PPS for only a predetermined number of months. Then after those predetermined months have been reached, the equipment will be owned by the patient. In 1998, the Balanced Budget Act, BBA, reduced reimbursement for home oxygen by 25% and another 5% in 1999. Sometimes these patients are required to actually pay for part of their supplies for home, or they're very limited as to how many they can have. So you will find a lot of patients that always ask for extra supplies for home because they may only give them so many suction catheters a month, and it's supposed to last them the whole month. So you'll find a lot of patients cleaning their suction catheters because they only get maybe one a day, which is very, very unrealistic. So the Deficient Reduction Act also reduced the monthly payment for selected respiratory equipment and added to the list of capped rental items. So by 2010, Patient Care and Affordable Care Act remains to be unseen in regards to the field of respiratory care. A lot of the care that's given in the home is done by nurses and techs and things like that. A lot of times they won't pay for a respiratory therapist to come. Now, there's some agencies where you have to have a therapist, at least to oversee a certain area for patients that have vents and things like that, but they are not in the home all the time. They won't go there like they would in the hospital to a person's room. The family is taught, and the RT will call to check on the patient and make visits periodically. So Medicare and Medicaid programs apply to home oxygen and ventilator, mechanical ventilators, but not as far as the RT time. They don't always want to pay for that. So the AARC continues to promote legislation and sponsor efforts to extend the recognition of RTs, so they can see how important it is to have an RT in the home, and it's not always effective to have a nurse take care of everything. We need to have RT there. We are important. We can do a lot more than the other caregivers. So in Table 51-2, you will see a listing of members of patient care team in alternative settings. You will find that everyone kind of has a role in alternative settings. So you want to do a utilization review, which of course advises and recommends the consideration of patient care, and they document in the patient's in-hospital care what's going on, so the insurance company will also know what is medically necessary. So the social worker gets involved in the discharge planning, brings all elements together, makes contacts with the outside agencies, and makes sure that things are kind of rolling in advance if the patient will need placement somewhere else. And then you have the doctor that writes the orders for patient discharge and evaluate the patient's condition and write the prescriptions for whatever it is they need, whether it's equipment or medications. And then you have respiratory care that evaluates and recommends appropriate care. They also do teaching and provide follow-up. Nursing care, of course, writes and implements their side of things, the nursing care, the planned care, tube feed, diabetic testing and things like that, and they also do their follow-up. The dietitian and nutrition is always important. They assess the patient's nutritional needs, write the dietary orders, and then make arrangements for the meals if necessary. And then you have the other side of the therapies, where you have the physical and occupational therapy. They provide necessary physical therapy and recommend other therapies, whether it be in-home or in an outpatient facility. Then you have the psychology side of things. They assess the patient's emotional status and decide whether or not they need more counseling or support. And then last but not least, you have the DME supplier or the home care company, and they're the ones that supply the equipment to the patient in the home care setting. And sometimes even in the SNFs, if they don't have the appropriate equipment, they will reach out to their supplier and make sure that they have the right equipment in the facility, so when a patient arrives, they have what they need as well. So here in this slide, we're just talking about a little rule of thumb. When you're dealing with someone who's a non-professional caregiver and you expect them to do a particular skill for a respiratory patient, it's very important that the RT go above and beyond to make sure that the caregiver have proper understanding. What I would find a lot of times when I am working in a hospital, or maybe the LTech, and a person, family member or the caregiver is going to be assisting, whether it's a neighbor or a friend, you want to make sure they completely understand. It's not uncommon for us to give them written information like directions, because they will not understand everything as we do. They forget things. They don't do it all the time as we're used to doing it. So you want to make sure you have pictures, you have step-by-step instructions on what they're supposed to do. You want to go through the skill over and over with the family member and patient, show them first, and then the next time the skill needs to be done to the patient, have the caregiver also demonstrate. And you want to also go through maintenance, equipment setup, troubleshooting, and kind of reinforce these areas to make sure they're comfortable and they have mastered the competency. And this concludes the end of Unit 2, Section B.